Hey everyone, welcome to our new online platform. I don't know how this is going to work for the first time, but we're just going to go ahead and give it a try. Reason is we want to continue with our competencies, and due to the COVID, we cannot meet in person. So I just want to kind of keep this going and kind of talk you through it. So hopefully it works out all right. So this is going to be for our second mandatory competency, and it's going to cover CRT and air entrainment on ECMO. A little bit of basics about the continuous renal replacement therapy. The device we use currently is the PrismaFlex. It's used for a 24-hour period and used to control metabolic control, fluid removal, acid-base control, and electrolyte balance. Few things about the PrismaFlex. This is more related to the nursing, that it's usually changed every 72 hours, or 780 liters process. We all know that it can be returned at the end of therapy, and it can be set to recirculate for 2 hours if we have to discontinue, such as oxygen change out, system change out. Hopefully the circuit is, the patient, I would say, is systemically anticoagulated, and the PrismaFlex can sit there and recirculate for 2 hours, so we can put it back on when we get done changing out the circuit or the actual oxygenator. For transport, there are rare occasions that we do bring it into the OR. For most purposes, we discontinue it, but do know that you can transfer with the PrismaFlex. It's a little difficult, takes more than one perfusionist, but we've done it in the past, and we may do it again in the future, just so you know. A little bit about the PrismaFlex disposable set. You can see the information and details right there on the screen. The blood flow rates can go anywhere from 100 to 450. Typically, we run it at 300 or 400 mLs per minute. A little bit of information on the details of the PrismaFlex. We pretty much use it for, or continuous renal replacement, I should say, for acute kidney injury and fluid overload. We typically use it almost 40% on all of our ECMO patients, so we use it pretty aggressively as far as treating for fluid overload here at Presby. So some of the devices we have for fluid removal, and just give you an idea what other centers are using across the country. About 51% use a renal replacement device. Still 21% use an inline hemofilter, and surprisingly, 23% of the people performing ECMO do not use anything for renal replacement during ECMO. This diagram shows two different ways to set it up. I would say B, if you look at B, how it's drawn, that follow the arrows. Here at Presby, we take the axis, it's positive pressure post-pump, goes through the PrismaFlex and is returned to the negative side. Some of the disadvantages are you are returning to the negative side, you have to watch for air entrainment. A is another way you could run the CRT in a positive pressure mode. It is pulling post-pump positive pressure through the device and returning back into the circuit pre-oxygenator. So there's some pros and cons we listed here. With continuous renal replacement, you have more accurate fluid management versus the inline hemoconcentrator. You get to remove a lot more volume. It's more effective as far as using your rapid control of metabolic acidosis. And it's actually stable for using patients that are on VA ECMO. So there's shunt, so it really does nothing due to with their hemodynamics. Cons, it's a little expensive. You do get more hemolysis because you're going through the lower lock, and you get some shear stress and high pressures. Sometimes you notice we get a lot of alarms when we first initiate the CRT, so we have to use either we don't use the Hoffman clamp here, we usually turn the stopcock to adjust the pressure going into the access line. So to set up, if you guys all seen it, the big things are the access line gets hooked up to the ECMO circuit post-oxygenator. PrismaFlex return gets hooked up on our negative side, and connections are done aseptically without any central line connection. Just remember, we always say the most important thing with the PrismaFlex or anything we use to hook up for fluid removal is we do access a return line, and there's always that potential for air entrainment. This here is just a little picture of the access line where we draw it. You can see it's hose pump. It's the same port we use for measuring samples of our oxygenator blood gases. And then the negative side is a little blurry on this picture, but you can see it as we use the same access we do for our negative side. So again, we run our access through the positive and return through our negative side. Here's a little demonstration of being hooked up. So right here, we're going to go ahead and hook up the negative side. Hook to our negative port. Important thing is you want to aspirate that little air bubble gets caught in that lower lock and stopcock. You see the guy in the background with flip-flops walking around the unit. You see just a little aspiration. You don't need a lot just to get that stopcock bubble out of there. Okay, once the negative side is done, you go to the positive or access side. Doesn't matter what sequence you put this in, the positive or negative. I just always do the negative and positive. I don't know why. So here we are putting it on, hooking it up, and do the same procedure of aspirating that little air bubble out of the stopcock. So now open up the return line, communicate with the nurse. They're ready to run. Open up the negative side. And I'll always watch the negative side just in case in a rare event air does come, I can shut it off. Then you can see the fluid flowing from the access through the prism back into the negative side. I usually sit there and watch both lines. It takes less than a minute to make sure I have no air entrainment coming through. Never had seen it before, but you never know. But once I see the blood coming through, I know I'm good, and then we'll set the parameters on the PrismaFlex. As you all know, we do return the blood at the end of therapy. Very simply, with communication with the nurse, they'll go ahead and get a bag of saline, use a spike line, and usually with the return, we go ahead and spike it from the positive side, pull it from the bag, and flush all the contents of the PrismaFlex set back to the patient. Once you're done, sterile caps on both things, and we always like to put one of those blue dialysis clamps on the negative side for safety. And remember to make sure you put off CRRT and peri-ups. So now we're going to talk about the hemoconcentrator. We don't use it that often, but we still do use it, so I'm going to talk a little bit about that. How we have it set up, you follow the arrows from the pump. We go from positive side into the hemofilter and back into the negative side. Same connections we use for our CRRT or Prisma on pump. Hemoconcentrator is just going to remove the fluid volume, and it's controlled by the Alaris IV. A little bit the common pros and cons. It's pretty simple in design, inexpensive. Same thing, and you do have a shunt, so you don't have to worry about it as far as hemodynamics on a patient. It loses less prime volume in the CRRT. Cons, unfortunately, it's like pieced together, so you do have to set it up. You have to use an IV pump to control your ultrafiltration. The extra things you would need with it is for additional external IV pumps is fluid replacement, dialysis, air rate up to 12% running at high rates. Basically, this is saying that when you run at high volumes, it's really hard to judge. IV pumps are not made to remove large volumes in a short amount of time, but since it's just for volume removal, that's really not an issue with us, the way we use it in our system. A little bit about the hemoconcentrator priming setup. You always get a nurse to get your Alaris pump, cut the short length of the MPS or MP4 line, which I'll show you. The place on the outlet of the hemoconcentrator. You spike the MPS tubing with standard infusion set and connect the infusion set to the Prisma waste bag. Waste bag hanger can be attached to the cart. Priming techniques, it's a little difficult to prime and set up. We hope to get you guys back in the lab sometimes to practice priming up. It's a little difficult to get some of the air removed from it. It just takes a little bit of time. But you connect a primed bypass pump in the pump room with, and like we normally do, use the pump to prime. 2 clicks on the outlet of the clamp to force any fluid to prime the IV line. Very important to de-air the segment that clips into the IV pump. Connect to the circuit, pull from post-auctioneer, return pre-pump, clip infusion set into the IV pump. And then you go ahead and set the IV pump for basic infusion, set the rate, removal rate, and volume to be delivered, usually at 999. It's the highest it'll go. Now, like I said, the hands-on, this slide here is a little busy, but we'll get you on everyone together so we can do a hands-on priming. So here we have what is all included with the hemoconcentrator, what you need for setup. We have the hanger, the infusion, the IV set, the waste bag, the MPS lines, and the hemoconcentrator itself. As you can see here, we have everything put in a bag. You can find this on the CTICU ECMO cart. Everything you need is found within that bag to set everything up. So the only thing you would actually have to ask for is the Alaris pump itself. Here's the Alaris pump. I'm sure you've all seen it. Again, the volume delivered is 999. Set the rate to removal. Say if you want to remove 100 ml an hour, you just set it to 100. Biggest thing problem with this is air bubble detection. It'll pick it up. So you may have to aspirate that line or kind of tap and get them bubbles out before you put it in the actual holder of the Alaris pump. So inline hemoconcentrator versus renal replacement therapy. So we have inline, you can see I'm not going to read all these here, but basically our inline hemoconcentration is just going to remove fluid. It's not going to remove electrolytes, and it'd be as more specific as you do as far as a inline hemofilter. Again, we don't use the hemofilter as much as the CRRT machine. Now we're going to talk about air entrainment. It's probably very difficult to talk and not do it hands-on, but the most important thing is, I think we all know that, but we'll just mention again, that everyone needs to know where you can train air, and that's on the negative side of the circuit. That's from the tip of the venous cannula to the inlet of the pump head. Again, we put this in here to be more hands-on, showing how to put the 3/8 connector on the negative side. When you hook things up, sometimes you get a patient that doesn't have that 3/8 connector or access line into the negative side. So that was the purpose of these slides, but it's always important when you access that. The other thing is where the air entrainment can come from. Open stopcock when hooking up any devices, or measure negative pressure from the circuit itself. And then you got to watch for when they're putting a swan, and anything on the right side can entrain air into the ECMO circuit. So managing ECMO, the biggest thing is, I'm not going to read this verbatim, but it is, once you do see air or hear air, is to clamp the circuit closest to the patient and entrain it. One thing we do when we practice in the lab is air entrainment and how to get it out. It's very difficult to simulate in the lab when you have blood versus water, because in the lab it's pretty much easy, but on the patient in the clinic, once you get air in there, it gets real frothy and it is very hard to move. Our thing is, you look at it, you make that decision. If you get that air out quickly and back on, is to do it. Most of the time, you would have to resort to actually just clamping the circuit out and changing, which is a lot quicker. What we try not to do, it's a judgment call, but what you don't want to do is sit there for 10-15 minutes trying to get air out and can't get it out, and then have to resort to put another circuit on. So if you feel more comfortable changing out the circuit, or you feel that's the fastest way to get the patient back on ECMO, we suggest you just change out the circuit. Thank you. That's my dog there, Pepper. I had to throw that in there. Thanks, guys. Appreciate it.